So today we have a patient with a grade 3 nuclear sclerosis with a mid-dilated pupil who was planned for a clear corneal phacoemulsification. On a closer view, you can actually make out the dense fibrillar pseudoexfoliative material present 360 around the anterior lens capsule. A side port entry is created with the help of a stab incision, and trypan blue dye is injected into the anterior chamber under the air bubble. A balanced salt solution is used to wash off the dye, and viscoelastic is used to create a tight anterior chamber. Now we come on to the crucial step of the capsular axis. As you can see, this pupil is mid-dilated, so we need to create an adequate sized rhexis. A flap is first raised, and this is then guided in a circular fashion. It is important that we do not use the size of the pupil as a template to determine the size of the rhexis. A useful trick is to make sure that the flap is in a folded triangular manner throughout the entire procedure. This reduces the tendency of the flap to run away towards the periphery, especially as the rhexis is being performed blindly underneath the iris. A slightly larger than usual capsular axis margins will also reduce the occurrence of capsular phimosis, which is usually common in patients with pseudoexfoliation and cataract. A clear corneal entry has been created, and hydrodissection is attempted by injecting a fluid wave underneath the anterior lens capsule. Always tap the lens in the center to decompress the capsular bag. The superficial cortex is first removed from the surface of the nucleus, and a central trench is created to debulk the nucleus. Now, by burying the probe into the core of the nucleus, a sharp chopper is taken to the mid-periphery of the nucleus and a combined phacochop is initiated. The nucleus is then rotated, and once again burying the phacoprobe into the substance of the nucleus. A chunk of the nuclear fragment is then lifted up and brought out of the capsular bag in order to reduce the stress on the zonules, especially in these cases where there is a dense cataract and a pseudoexfoliation. The rest of the phacoemulsification of the other fragments takes place in a similar manner. The second heminuclei is also chopped further, and the emulsification is done within the pupillary plane, which is the safe zone. The second half is also chopped and made sure that the piece is separated and broken down into smaller fragments in order to reduce the phaco power, as these pseudoexfoliation cataracts have a reduced endothelial count as well. Now we proceed on to the bimanual irrigation and aspiration of the cortical remnants. There are two challenges that we face in these cataracts. The first is to remove the cortical matter and then the epinuclear sheath as well. So initially we tried to get a hold of the anterior leaf of the cortical fibers in order to bring them to the center and then aspirate them. A useful tip while doing an irrigation and aspiration in these cataracts is to watch out for the capsulorrhexis edges. If there is any undue movement of the rhexis margins, this could imply a disruption of the zonular fibers, leading to an instability of the capsular bag. Next, we try to remove the epinuclear sheet, and with patience it is slowly maneuvered, and once the sheet is free, it is then aspirated. Now, under irrigation, the foldable intraocular lens is injected, gently making sure that the leading haptic goes underneath the anterior capsular margin. And with the help of a dialer, the trailing haptic is dialed underneath the capsular margin as well. Finally, with the help of a dialer, we retract the edges of the iris to make sure that the haptic as well as the optic is underneath the anterior capsular margin.
Finally, the side ports and the main wounds are hydrated. One day post-op showed a diffuse corneal edema with mild SKs. 1 week post-op showed a clear cornea with pseudoexfoliative material at the pupillary margin with a final visual acuity of 6/9.